on switch on mode. Well, if you can hear, fine. Welcome to today's program. Before I start, just one request: keep your mic mute from your side because noise goes around. So, welcome to Virtual Knowledge Network, Nimhans Echo. Today's this session is on Road to Recovery, being led by Psychiatric Rehabilitation Services. Rehabilitation service differs according to the clientele and available resources, and one need to learn from best practices relevant to Indian context. The whole purpose of this session is to transfer the wisdom which we all gain from our clinical practice. Again, the objective is to reduce the variation of standard in care, sharing the best practice model, sharing of wisdom along with clinical practice guideline, and continued training and hand-holding and rather than single sessions. This is a collaboration between Nimhans, Bangalore and Project ECHO. ECHO stands for Extension of Community Healthcare Outcome, University of New Mexico Healthcare Centers, Albuquerque, US, and ECHO India. It's supported by Government of India, Center for Addiction Medicine and Nimhans. This is the 3 pilot session which rehabilitation team has started. Today's second session is on, I think, community-based rehabilitation using government's resources. I'll come back and tell today's agenda. We have, although this is standard format, there will be a case discussion followed by a didactic. This is most important. I think, fortunately, most of the people who are logged in are familiar to the system. Those are newcomers. Please keep your mic mute when the session is in progress. The whole reason is that the recording is going on and all the recordings are going to be uploaded in the web once it's over. Try and minimize environmental noise near around. In this session, while going on, in case you want to ask something, you can raise your hand or you can chat to us. Chat is active. You can see in the down button there will be a chat thing. You can chat to us through it's a VKN. Nimhans is our login ID from our side, or you can, if you by default you chat, it goes to everybody. Yeah, that's fine. Now today's presentations, I think I will hand over to Naveen to start with this. Dr. Naveen, who is my colleague, will start this. I think before I probably hand over, I have a round of introduction so they will know each other at least, although most of you are familiar. Okay, let's start from here. Okay, myself Prabhat, I am an additional professor of psychiatry and I am an addiction psychiatrist. Okay,
I'm Krishna Prasad. I work as a faculty here in the Psychiatric Rehabilitation Services.
I'm Abhishek Pathak. I'm senior resident on Psychiatric Rehabilitation Services. I'm Dr. Harish, working as assistant professor in Psychiatric Rehabilitation.
I'm Dr. R2R. I'm working as an assistant professor of psychiatric social work with Psychiatric Rehabilitation Services.
Yes.
Hi, I'm Aparna Mahesh. I'm a psychologist. I have my own center in Bangalore. I work for addicts, drug addicts and alcoholics.
My name is Jagadish. I'm a professor of psychiatry and I am associated with Psychiatric Rehabilitation Services.
I'm Sivakumar. I work as assistant professor of psychiatric rehabilitation here.
I'm Naveen. I'm associate professor of psychiatry at Nimhans. I'm a member of the Psychiatric Rehabilitation Services.
Yeah, I think I'll request online participants to introduce yourself. Now, what you can do, you can unmute your mic and you can start. I can start the names. I can start with Anubhav. Anubhav, I know know you very well, but it's good to introduce yourself and which place you are.
Good afternoon, everyone. Myself, Dr. Anubhav Rathi. I am logging in from Ghaziabad, Uttar Pradesh, and I am into private practice.
Thanks, Anubhav. Thanks and welcome. Cherian John. Cherian, can you hear us?
I think it's Scarf.
Yeah, it's a Scarf. I think let them come back. Okay. Then Arun from CMC Vellore. Arun, do you have mic with you? Yeah, it's mic. You can unmute the mic. Okay, Arun has sent a chat. Okay, no mic, it in the mic. So Arun works as a faculty at CMC Vellore. I think Arun is interested in rehabilitation services, correct? So Arun works as a faculty in rehabilitation services in Vellore. Manoj, Dr. Manoj Kumar, I mean, yeah, you will speak up.
I'm from Mental Health Action Trust. I'm at Calicut, and I'm one of the speakers.
Thanks, sir. Dr. Pfizer, Unmute. Fine. We are missing. I think it'll come back. Okay. No mic. Okay. That be fine. So Dr. Arun is accompanied with him. Dr. Stephen and Dr. Silpa from CMC Vellore are also attending this program with him. So they don't have a mic. I hope Arun. I think is long due for you to get a camera. I mean, Arun has been there for a long time, 1 year, and I think you do it. If you need any help, let me know. I can help you out. I think they have actually contacted the CMC Vellore telemedicine device in touch with us, and they want to make a program in the institute. Dr. Ravi Shankar Rao.
Yes, I'm Dr. Ravi Shankar Rao from Bangalore, and I represent Chittadama, the residential rehab center for homeless people with mental illness.
Thank you, sir. I think Chellamuthu Trust. Mike is.
Yeah, good evening.
Yes, welcome, sir.
Yeah, good evening, sir. And on behalf of the trust, being a director programs of Chellamuthu Trust, we express our sincere thanks for giving us a wonderful opportunity to share some of our experience in the field of community-based rehabilitation. Along with, we have our multidisciplinary team to watch and share some of our experience.
I'm Prof. Koodalingam, teaching substitute. I am with the trust for the past 50 years.
Fine, sir.
Is there a problem with this mic?
Okay. I think SCARF team has sent a SCARF. SCARF Chennai has joined from. They have Dr. Subhasini, who is a psychologist, and they have DNB students. Subhasini or Cherian, do you want to introduce yourself? It will be nice to hear from you. Yeah, unmute.
Yeah, this is Subhashini, psychologist, working with staff for the past 10 years. Been involved in the psychosocial rehab program of SCARF. And we have other DNB students with us, Dr. Vidya Mohan, Dr. Aparna, and Dr. Adarsh.
Thank you. Thank you very much. I can mute the mic. Spandana, is your mic? I think your mic camera is on. Yeah, you can keep the camera a little down. So, do you want to introduce yourself?
Unmute.
Yes. You can introduce yourself.
Myself, Dr. Sumit, sir, from Spandana, third year DNB resident.
Fine, thank you. And your colleague sitting side?
Ram Naresh, second year DNB.
Very good. Okay. So we have, thanks to all of you for your time, and I hope that this session will be fruitful to you. I will pass it to Dr. Naveen Kumar, who will be my colleague and will be going to moderate the today's session.
Thank you, Dr. Prabhat, and it's indeed a privilege to moderate this particular program on community-based rehabilitation. We have, along with this distinguished gathering. So, what will happen in today's session is first presentation will be by the MS Chellamuthu Trust and Research Foundation, Madurai. That will, their presentation would be divided into two parts. Initially, Mr. Janardhan Babu will be presenting about the activities of the Chellamuthu Trust for about 15 minutes. We can have a discussion for about 10 minutes later on. And then Professor Koodalingam, who is the program advisor, will be presenting on a patient. That will be a case presentation for about 20 minutes, and then we can have a discussion. After that, we would request Dr. Manoj Kumar to have his presentation. Now, I invite Mr. Janardhan Babu to start with his presentation.
Give me one minute time. We'll stop the share screen here. Yes. Yes.
Yeah, yes, Mr. Babu, you can start your presentation.
You have to.
Yeah, maybe just give us some time.
Yes. Now it's visible. Yes.
Hello. Yes, sir.
Good evening. And designated as programs of Chellamuthu Trust and Research Foundation. And once again, I consider it's a great privilege to share about this evening presentation. And this PowerPoint presentation going to enlighten you about the core programs and activities of Chellamuthu Trust and Research Foundation being carried out in the last 2 decades of services in the field of mental health. So, next slide, please. And this Chellamuthu Trust, established in the year 1994, founded by C. Ramasubramaniam, a well-known psychiatrist, who also happens to be the state nodal officer for the district mental health program for the state Tamil Nadu. And we claim ourselves as the largest mental health service provider in down south Tamil Nadu. And if you see the vision of Chellamuthu Trust is mental health for all, and the vision and the mission is promote mental health through holistic mental health care that is affordable and accessible to all. And when it comes to the program per se, you can classify the Chellamuthu Trust services under institution-based and community-based. And the institution-based program, we have a Center for Psychiatric Rehabilitation where persons with mental illness being given care in psychosocial rehabilitation. And next to that, Center for Differently Abled where persons with mental retardation, we have special school, we have adult residential rehabilitation home for the special children. Followed by that, we have Center for De-Addiction, which is supported by Ministry of Social Justice and Empowerment, New Delhi. It is a 30-bedded De-Addiction hospital. So these are all the core area which comes under institution-based rehabilitation setting. And we strongly felt in the year 2000, so we have moved out to the community with the support given by Andheri Hilfe, where the next few slides probably our program advisor, Professor Koodalingam, will enlighten you on more about the community mental health program. And apart from that, we do have services called religion and mental health. Of course, there is a neighboring district called Virudhunagar, where we started way back in 2001, where this is Sivakasi, once again community mental health project. And the world definitely witnessed in the year 2001, where the very great tragedy happened at Airwali. So since then, Chellamuthu Trust become the technical expertise in serving the community-based rehabilitation at Rammad.
Yes, yes, I think, sir, 1 minute.
And as a credit, and we highly honored from Chellamuthu Trust for the good work for the services to the persons with mental disabilities. In the year 2007, Chellamuthu Trust being awarded as the best institution award, recipient of the national award by then President Pratima Patel. And similarly, the recovered persons with mental disabilities who have won the National Trust Award in the year 1999 and 2008, and in 1999, another person who won the Best Employee Award. So we feel highly honored, and it's a great privilege.
Activities since 2000. This project was supported by other in field Germany, and the focus of this program was to take the health treatment and rehabilitation to those who are. So we have selected around 200 villages, and wherein we were organizing treatment and rehabilitation programs to the poorest of the poor, the mentally ill who are who are suffering in the families of the poor in villages. The various when we were starting this by 2000, we found that there are a lot of people in and around Madurai city where they have not taken any treatment. They were left uncared, and when we meet the families, we found that they are highly ignorant. They were even not aware that there is treatment available for the mentally ill patient. They also have a lot of stigma towards disease that led us to take up this massive project.
Hello, sir.
Treatment around 300 mentally ill person who are very severely affected. And there are various steps we have taken up in implementing this project. As you have seen in the slide, we were taking a lot of steps in identifying the disabled in the villages, while then we took up treatment in villages by camp method, and we have also provided treatment in the camps, and we were also giving a lot of training to the disabled and their families on the continuous treatment, because many times people wanted to take treatment for 1 or 2 times, and then they wanted to see that if it is not cured, and they will discontinue. That is the attitude of the people. So we have insisted that the continuous treatment is important, that we have taken up to the villages and to the families, and we have given a lot of awareness training to the families, and we have been providing counseling to family members through visiting their homes individually, and after that the treated mentally disabled were given some training in order to get them some skills. Thereby they can involve in some income generative activity, and thereby we have been implementing this for the past 13 years. So we found that it was very interesting and very successful program. Many people have even government organizations and various voluntary visited us and seen our success. So these are all some of the activities. The self-help group, we have started self-help group of the families of the mentally disabled, and we have given them training to the families as well as to their disabled member, and they were able to start some small income generative activities. The government was also very much happy to support, and the banks were lending loans, subsidized loan, and we were able to get around 20 lakhs for their income generative activities. And this we were able to advocating to all the families that their disabled member can be treated, and they can be economically productive in due course. So these are the various activities that we were very much concentrating, because the educating the mentally disabled in the family, motivating them for regular treatment, and handling the stigma, and organizing them as a community in order to motivate them to get involved in the rehabilitation process. So that was our success. So these are the number of people who have covered under various programs, awareness and training programs. Thereby we reach larger community and to tell about the suffering of the mental illness and the possibility for treating and rehabilitating them.
Maybe added to Professor Koodalingam, I would like to, if you see the table presentation, how the government people, in the sense they also involve like ICDS, integrated child development workers, voluntary health nurses, and the village presidents. Yeah, how the community as such involved in getting the awareness. Thank you, sir.
So these are
Dr. Koodalingam.
Yes, sir. Yes.
Can you just finish your presentations in another 5 minutes because the time is running out.
Okay, okay, fine.
We
So we have
quickly move to
Case presentation.
Thank you. So we wanted to tell you that we have succeeded in harvesting, in getting a lot of support from the government. We have a lot of the government has some schemes which we were able to get it and provided to the treated mentally ill people in the villages. For example, we have got a lot of loans for their income generative activities. We have helped them to get employment opportunities through National Rural Employment Guarantee programs. We have around more than 100 people are now employed in this scheme, and they are getting 100 days employment opportunity in villages. We have also got a house for the mentally ill patient, and the administration, the government and the district administration are very much supportive for our cause. Thank you. Thank you.
Thank you. Thank you very much, sir. Can you just quickly go on to the case presentation, because I initially told that we'll discuss, but then we'll take the discussion later. Can you please, progress with your case presentation? You can start your case presentation.
Okay.
So this is some of the thing where Professor Koodalingam highlighted about how the government resources utilized for this community population, legal aid, housing scheme, 100 days. I can quickly rush through these slides, which Professor already presented.
Hello, sir. We can take up the discussion later on. I request you to kindly start your case presentation.
Yeah. Yes. See, this is one of the successful case we have come across in our community mental health program at East Block of Madurai. Mr. K, with the age of, is a male with the age of 42 years, completed only primary schooling, unmarried, from rural Madurai. And while identifying, he was identified during our door-to-door survey. One of the components, main components in the community mental health project is identification through survey method. So as we rightly pointed out,
this is the picture, you must see it when we went to his house, and he was in the cattle shed. He was tied in a pole, and he was without any with water, and even he was defecating in the same place. The old mother was sitting with him, and she was the one who is looking after when we were identifying him.
Thank you, sir. So when during the survey made by our community mental health workers, CBR workers, way back 10 years before when the project launched in a place called East Block, and through door-to-door survey, we found this gentleman in a small hut without having anything. He was tied up with a chain. And on examination by our CBR workers, and we found complaints of delayed milestone, and there was a bit of self-talk, poor grooming, and not having a bar, saving, no eye contact, and he was totally socially withdrawn. And he was chained for years, more than 10 years and above, he was chained. And that was the situation we come across during our survey. And when you see the history of Mr. K, and during his milestone in a childhood age, he had a brain fever at the age of 4, and he was very dull in academics. And by the time they also come across, so these are all the things when we interact with the family, the significant members with the mother, we come across this history, and he do have behavior problems like beating the children at a neighboring place, and he distracted the class. So for which he was dropped out from the school. And then what happened is, when you see the family tree of Mr. K, and father, mother, and he has 2 elder brother, and he is the last one. And his father, who passed away at the age of 67, and he's basically a landlord and getting his income through some rental sources. And when it comes to the diagnosis part, the whole team, which constitute led by psychiatrists, psychologists, psychiatric social workers, nurse, and CBR workers. We all got trained in basic identification and assessment. So by using our tools, we come across the diagnosis of clinically mental retardation with schizophrenia. And on our psychologist, after measurement on VSMS, the social quotient of 60, indicating there is a mild level of deficit in its function. So that was a thing. So after that, once we have been diagnosed, the challenges faced by our community-based rehabilitation worker, when we made a home visit, and we faced a lot of challenges. And some of the challenges is non-cooperative and aggressive at the time of first level of intervention with the client. Then the distance to attend the camp place. And if you see the place from here and to identify his spot of residence, they have to travel almost 5 to 6 kilometers. There was no transport during those periods. The community workers, they have to all the way go, by cycle, by using our own pedestrian, and reaching their place and offering the treatment and medication. And we also come across being a very remote village in a city like ours. So there are a lot of myths and misconceptions. And entirely the attitude of the family, because the father, the mother, and both the brother, they never gave a say to this gentleman, K. That is why he has been, thrown out from the family and in the head. And the psychiatrists, the team, and the entire professional make home-based treatment, because in the initial of our treatment process, we find it very difficult to bring him to the treatment campsite. So we decided as a team to move to his place and be a home care program. So if you see the slide, see our CBR worker and our treating psychiatrist who visit and give injection and pills on the door. And if you see the treatment part, he was given an antipsychotic with carbamazepine, chlorpromazine, haloperidol, anti-HD, and loracifim with a minimum intake of drugs. Even we have come across the challenges that the mother said, whatever the medicine you give to our son, we are not sure that it is how it is going to help, and you are going to give him some sort of trouble to our son. So that was the attitude by some of the family members, particularly in case family. And how we have break that barrier is our CBR worker, they make a regular follow-up visit on not only on the camp day, even beyond the camp day, we have to make a home visit and meeting the parents, meeting the clients, and giving the them on regular follow-up, and see that the intake of medicine is regular. And similarly, the credit also goes to the clinical, our nurse and the community care workers. They help the caregivers identifying the medication by way of color, because sometimes we also come across, since the mother also have done her primary level, you don't know which medicine, how to give, where to give, when to give. So we made a small suggestion by making difference there in the morning dosage in a cover like yellow, afternoon in a brown, and the night in a white, which is written. So that the community workers, often lobbying with the family, the mother, to identify by making these colors. This is one of the challenges, and whereas we have also addressed the challenges in this form of thing. And if you see the medication, though the project is supported by a German-based organization called Anderi Hilfe. So we have a small fund to assist to procure medicines from that side, which is also insufficient in some of the times because we have a client profile of larger one. So to address that also, the project emphasized the caregivers to come forward to contribute, because so that we felt that there must be some sort of family contribution, whether it is logistic or physical or as well as in a professional enrichment. So we request the family members minimum contribution to support for the drugs. And above all, as I told you in the introduction of our talk, in Tamil Nadu, we proudly claim that in some of the districts, the district mental health program achieved in a greater extent, it reaches to the remote villages by providing some basic psychotropic drugs. So we want to utilize that opportunity to our people. So we have also procured medications from district mental health program and the primary health center, and some of the medicines from the village to reach the government headquarters hospital in Madurai, they have to travel 6 to 7 kilometers. So we have also tied up with some of the medicines to get it from the government Rajaji hospital, drugs like for epilepsy. So those are all the medicines channelized through GRH. So this is one way of thing, getting the medicines. And when you see the frequency of visit by the community-based rehabilitation worker, CCW, they wake once in 3 days. The project coordinator with a background of social worker once in a week, and the professional trained social worker once in a week, and staff nurse once in 3 days, and the special educator once in a week. And the medical officer, it is all need-based only on the time of the camp, or if there is come across any side effects which is needs a medical emergency, in that phases we sought the help of the medical officer. If you see this overall this slide, the frequency of visit by the team is highly phenomenal and very committed. And if you see the intervention and the engagement, the patient and the family members, of course, for the patient, the client, we made regular home visit, and we ensured that the adherence to the medication is regular without missing any dosage. And apart from that, is the project also focusing on having a daycare services inside the community itself. So we have requested the client to come and avail the services of daycare. Similarly, for the family members, frequent counseling, psychoeducation, and above all, the mother, to make her livelihood, we have enrolled her in self-help group called Nambikai, which literally meaning is hope. And also we have made her to avail the government benefits of disability certificate and the MG grant of ₹1,000. And similarly, we also have a lot of hurdles to get him a disability certificate. Of course, our team had a lobbying frequent with the district disability able welfare officer, and through their guidance in those periods, we availed the disability certificate through licensed through recognized GRH practitioners. And similarly, the project also emphasizes on setting up a small model vocational training center in the village itself. So we have involved Mr. K in daycare center. After making assessment by our team of experts, we found he is good in some sort of stereotyped activities, some semi-skilled labor. So we thought better he will be much benefited from some sort of gardening based skill. So we got him from there, and we have entrusted some small garden activities in one of our rehabilitation center, which from his village he has to travel for another 6 kilometers. So we have given him a placement there as a gardener, and we're proud to see that after 1 or 2 years of regular intervention, we have given an incentive, of course, the salary of monthly, because it is a direct and motivation for Mr. K to take up this venture for a longer duration. And when it comes to the topic of today's presentation, how this particular case, how we extract the resources of government resources for this particular case, of course, as I told you in my earlier presentation, some of the drugs we got it from government Rajaji Hospital, district mental health program, and project fund. Above all, the maintenance grant of ₹1,000 we have offered him to this family. And Mr. K's mother, he was an active member in Mahatma Gandhi National Rural Employment Guarantee Scheme, which is being a very successful, good practice we all consider in South Tamil Nadu of 100 days employment. He has given that opportunity, his mother. And some of the challenges which we have come across is drug adherence and monitoring. And sometimes our community-based CBR workers, they sometimes also find it the monitoring of drugs. Sometimes on one occasion we come across the night dosage of drugs might have been switched because of the continuous monitoring. So we have tried out for making through mobile or frequent visit to the families and insist them on taking all the dosage to take it on a regular basis. And since Mr. K, the two brothers, the father is a landlord, he has some property. So the two brothers, cleverly, they don't want to give some of the properties which after continuous follow-up with this family we come across. So we sought the help from the legal aid services, which we got by the Legal Aid Services Authority of Tamil Nadu. So they have been visiting our center weekly twice, offer the free legal aid service to our disabled population. So we sought help from that legal aid services. And apart from that, the family support system, we involve the mother and making him to make their livelihood. So that makes her more self-confident, at least to support to her children, Mr. K, to get medicines to provide a daily bread. And similarly, to open the maintenance grant account for Mr. K, in the initial, we have some inhibitions to move with the government bank officials. So the project made an effort by making some small internal loan to the family members. We invite the bank officials to come and witness the successful practicality. So after seeing the good work, the officials also come forward. They have been enlightened that such good work is being practiced. So, and they have come forward to support in opening bank account and lending this maintenance grant. And similarly, we also had a close tie-up with the DDAO office and district administration, along with the local NGOs. So once in a year, in Madurai district, we have a job mela, placement mela. And so we also identify the people given job training and placement with the help of the district administration and some of the NGOs and corporate sectors in Madurai district. And on the whole, if you see the outcome of this particular case of K at individual level, considering the regular monitoring of 10 years of our intervention, much symptoms have been reduced, and he can also able to express his own needs and able to perform his activities of daily living, which he was lacking in the beginning of our identification. And we assist his mother in carrying out his household activities, how to do that. So mother have been given training, and now he has become an earning member. So once Mr. K becoming an earning member, the entire attitude of the not only the family, even the village witnessed a great thing when he was not wanted by his own community, when he was not wanted by his own family. Once he became a productive member and doing a regular work in the garden and earning a livelihood of 2,400, and the entire community and family of Mr. K become witnessed, and they gain more self-confidence. And my dear observers, you can see the pictorial picture of this Mr. K. And if you see the before treatment, this is the scenario we have identified. And during the treatment, the team visited home visit, they give treatment. And after recovery, almost if you see a man in a mainstream integration with neatly dressed, for us it took almost 2 to 3 years to make him to this level. It's a great challenge we have come across. And see the outcome of a total family level, and the mother become an active member in a supportive groups. Here I would like to say that when we call for a group meeting in a community level, his mother we take an active part to mobilize the group, supportive groups in the village. Any program to reach the village, through people like case mother, they become an active member. And also we started taking some of the income generating activities which is of need based one. When Professor Koodalingam pointed out through self-help group activities, some of the laundry, bakery, and vegetable, there are a lot of things we have started through IGP activities, which is of locally relevant made to the families. And so that made the family enhance their self-sustenance and for buying medicines, and they gave me a social respect and able to manage crises at times and emergencies. This is the general outcome.
Mr. Babu, could you please complete your presentation in the next 1 minute?
Yes. So above all, this community program mental health project made the entire project awareness among community that brings considerable changes in the persons with mental disabilities, convergence of various government schemes for the benefit of the persons with mental disabilities. And for any success of this community, we must always showcase the good success stories resulting in attitudinal change. So thank you very much for giving all of us a great opportunity to showcase some of our cases in relevant to community-based rehabilitation. Over to the group, sir. Thank you.
Thank you. Thank you, Mr. Babu, Professor Koodalingam, and the team from the MSCT. So now the case presentation as well as the presentation on MSCT is open for discussion. So our members can please raise their queries, clarifications, questions, doubt sessions, whatever. Now the presentation is open for discussion.
Can I start?
Yes, sir, please.
I'm Jagdisha. I'm sitting here in the VKN center. I have a question to the Chellamuthu Trust people. Sir, how much of involvement was there from the government manpower in your services? What was the involvement of the ANMs, village rehabilitation workers, medical officers? Could you please throw some light on that?
The medical officers are coming to the camps 4 times in a month. So they are given a honorarium around 5,000 per medical officer for his visit. And for the leader of the team, we have given around 15 to 20,000 rupees. For community care workers, it was around 3,000 to 5,000.
I'm not asking about honorarium. I'm asking about what was the involvement of the government system in your community-based rehabilitation. What was the role of NGO versus the role of the government?
Role of NGOs is government. The government was encouraging by providing various welfare schemes available with them. For example, when we wanted to provide them ID card, identification card, that is a basic requirement to avail any benefits in the government. So those who are having more than 40% of the disability are eligible to get government grants. So whenever we take the disabled for assessment to get ID card, the government medical team and the government rehabilitation office are very much cooperative.
Excuse me, sir. I think what Dr. Jagdisha is mentioning is how much cooperation was there from the government side with respect to the manpower. These benefits and these drugs are there from their side, but like ground level manpower, like village level health workers.
Manpower, listen, they cannot give human resources. They were participating, they were encouraging. For example, the nurses were given training in the PHEs, for which they helped us to organize training. and they all assembled. They were listening to us. This is how they were cooperating with us. For example, when we went to school for awareness to the school teachers, they were ready to cooperate with us. They have organized school teachers for awareness meetings. They helped us in conducting awareness to the school children. Like that, they were supporting in all these schemes. Yes. Are you clear?
Yeah.
It is a project of an NGO which is serving in the village.
I'm just wondering if another community has to replicate what you have done. I think you have done a great job. I think we are all very impressed with what you have done. So I just wanted to check if we have to replicate in another community.
Yeah, we have been replicating it. For example, what we did in one block is now we are replicating in 2 other blocks in 2 other districts. So we have improved some of the schemes which we have done it in the 200 village in the initial stage from the year 2000. We have worked in 200 villages for the period of 13 years. The experience in 13 years, we have taken it to other parts of the district and other districts. Now we have been covering around 500 villages in 2 districts. The same is being now replicated. And also the government is also taking up this model. We have provided consultancy to the government programs. Now in Ramnath district, the same model is replicated in Ramnath district. That project is being run by the government department itself. So then now it is being replicated. And we have also provided consultancy to the government of India to evolve a model at the national level, for which we were approached by the government of India to evolve a model, outreach model, community outreach model, which we have given this experience as a model to the government. The government will take up in due course.
Okay, Dr. Arun from Vellore, he wants to put up his viewpoints. Over to you, Dr. Arun.
Arun, you can come. You speak.
You can just raise it.
Dr. Arun from Christian Medical College, Vellore, has a query that often they hear from their patients that local administration, the VAO and the Taluk office demands bribe. What's your experience and how did you tackle this? Is a query that Arun has.
It involves no bribe in the sense, after having seen our work in the villages, the government took it as an opportunity to support us. They were very much happy to come forward to support us. For example, the collector was personally visiting us, and he was meeting our treated persons and the families, and he was encouraging their staff in the government to support us. For example, when having seen our self-help groups organized for the family members, the banks, there are 3-4 banks, they came forward, they have supported, they gave around 20 lakhs loan for 13 self-help groups. So there is no bribe involved in it. They took it as an opportunity, they took it as a prestige to support us. No bribe, only pride.
So he goes on to add then that most often district officers and doctors seem to be cooperating.
Yeah.
But I'm not getting it. Sorry.
No, he goes on to add, Dr. Arun goes on to add then that in your case, most often disability office and the government doctors seem to have been very cooperative.
Yeah. Yes.
Which may not be the case, sir, in other cases, because
I think the clout of Chellamuthu Trust has made the government machinery work better in your.
We were mutually supporting each other. For example, the government wanted to project some of their work. They show our successful stories to their higher officials. So mutually we were working together because this is for both the government and the NGOs are working for the people. So they felt also working with us is a good opportunity for them. They also took it as a in working with us,
and
they feel proud of it.
Yeah. Added to Professor Koodalingam, I would like to also point out when the previous speaker asking about the question how the support system, even we support, see in Madurai, of course, in every parts of Tamil Nadu, on Monday they have a collector's grievance day cell. So the district administration collector used to hear all queries. Even from Chellamuthu Trust, we support the different departments of district, DRO, DAW department. We send our manpower for assessing them, and because of the good work, the entire district administration, they have come forward to offer a place in the district administration block itself to showcase our livelihood activities. So we have our departmental store run by the families of the mentally disabled in the name of Nambikai. In the center of the place itself, we have a departmental store, we have a laundry shop, which is all support given by the district administration. This is for a piece of information.
Currently, we have a MOU with the veterinary university, government veterinary university, and we have been organizing a vocational training on dairy farming. So this is people, the government departments, dairy departments come forward, and they also support innovative ideas. For example, we are the one who have initiated job opportunities, work opportunity in villages, National Rural Employment Guarantee Program. The Chellamuthu Trust, the trust which has initiated this innovative idea, now it is taken up throughout India.
Thank you, sir. Are there any other questions from other participants?
Yeah. Yes.
Okay, Dr. Aarti here, she has a somebody else? Okay. Anybody else from the participant team?
Yes.
Yes, sir. Dr. Ravi Shankar Rao.
Okay. Welcome.
Can I speak?
Yes, sir. Please.
Yeah. Now, apart from the help that we had from government-sponsored schemes, which appears very easy from what they are saying, but then I think experience has been a little different. Apart from that, the clinical aspect is concerned. How successful or how easy has it been to get over uncooperative patient, the attitude of the family, and the stigma that is attached to it? That is one major concern where we are concerned.
Yes, Professor Koodalingam.
Yeah, you are repeat. I'm not getting it. It's not clear. Sorry.
Repeat the question.
Professor Dr. Ravi Shankar Rao says how difficult it is to overcome the stigma and other challenges faced by uncooperative patients and uncooperative families.
Okay. For the past 50 years, what we come to know is that in rural areas, it's not that much stigma. It is the ignorance. And comparing with, though there is a stigma in villages, but the ignorance is greater when comparing with the stigma. When you compare the urban and rural population difference, the urban is having more stigma, though they are aware of the treatment available for the mentally disabled. They think that having a mentally disabled in their family is a stigma for them. Whereas in the villages, they are ignorant of this very fact that the mental illness can be treated. When you show us that mentally ill can be treated successfully and can be reintegrated in the community, there is no problem in dealing with the stigma in the villages. That is our experience. That you can also experience it.
Okay,
because
sir.
we have seen the moron, the most mentally retarded children who cannot be treated, who cannot be trained in any way. They care very, very, very carefully. You can see the mother taking the moron child to her camp. So where is the stigma? It is the ignorance only. They don't have any support. So we have to provide support, we have to provide awareness, and we have to provide the support, and we have to provide also treatment and rehabilitation support. That we have to do it. So that is lacking in India.
Okay, sir. The time permits us to have only one more question. Dr. Aarti.
I congratulate the Chellamuthu Trust for their efforts. A couple of things that
Yes,
I
please.
want to understand. A couple of things that I would want to understand is, one is you've spoken about various staff who have visited this particular patient for a number of visits, including the community level community level workers, the psychiatric social workers, the nurses. I would just like to know whether all of them went individually, what were their specific roles when they met the patient, if you could throw light on that. And another aspect that I would want to know is, you have spoken a lot about the Nambikai self-help groups and the financial activities associated with it. Could you just throw a little bit of light on whether it is translated into a proper microfinance project, and if yes, then possible model that you are using?
Okay. With regards to self-help groups, we took that because in 2000, during that time, the self-help group model is very famous. So everywhere it is, the self-help group was talking about it, and they were also getting a lot of support from the government through bank financing. So
was this group more like a psychological support, or was it a microfinance group that you're talking about?
I have not completed. So we took this as an opportunity to avail the benefits that is available in the government. So that is the thing that we have taken. When we work with the department which is dealing with self-help group, they have given a lot of relaxation in organizing self-help groups. Ordinarily, the self-help group must have 20 members to start with, and those 20 members must be in a neighborhood, in a village. But they have relaxed all these rules for us. We can have even 6 members as a self-help group from various villages. So they have seen our activities, and they were very much supported this cause. And with regards to the visit to the villages, each member of the team visited based on the roles. For example, if the nurse is visiting, it is to see that whether the medicine is taken continuously. For that purpose, he has to visit frequently during the initial stage of treatment, because during the initial stage of the treatment, people do not take medicine regularly. They don't know how to take medicine and all. So to see that, to provide that counseling, the nurse have to visit frequently in few months in the beginning. And all community care workers must visit at least 2 to 3 times. We have made it as a target. They have to visit 2 to 3 times in a month, each person. That is how, because we have a component in the project that is called home-based, that is called home visit. That home visit, we made it as a program component in the project. In that, we have to see that they have to frequently go to the house and establish relationship with them, and must make everyone become the member of the family. Then only you can convince the family members. So that frequent visit helped us to strengthen our relationship, and that strong relationship helped us to change their behavior and attitude. So that is how we have succeeded.
Thank you, Professor Koodalingam and MSCT. Now I may request Dr. Manoj Kumar to start his presentation.
Yeah. Yes.
Hello. Thank you.
Professor Koodalingam, stop screen sharing.
Oh.
You need to stop screen sharing.
Okay. Thank you.
You need to stop screen sharing from the Chellamuthu Trust side.
Stop. Dr. Manoj, over to you. You can share your screen.
Okay, I'm just getting it up. See that?
Yes, sir.
Is that visible?
Yeah.
Okay. Before I start, can I introduce visiting psychiatrist from the UK, Dr. Parvez? So if you want an international perspective, I'm sure he'll be happy to.
Welcome, Dr. Parvez.
Hello.
Hello.
Pleased to be. Thank you.
Okay. First of all, thank you for the opportunity to share reflections from my personal experience. So because you have asked for that, I've kept it exactly that. So the focus is on what I think is related to this topic rather than evidence-based or theory-based. So overall, I'd like to make 4 sets of points. Initially, to argue for mental health to be seen from a very broad context. Then to go on to increasingly the feeling that we have been having about the importance of task sharing. Then to speak about quality aspects, and finally to end with the hurdles and issues that we have faced. So 4 broad themes. So let me start with the first, which is a very broad view of mental health. Now, the background to this is that until 6 years ago, like most people, I was also institution-based and institution-trained, and I all my life worked in large institutions. So for me, it has been a big change over the last 7 years to move to a completely different model of looking after people with mental illnesses, and that's why probably Shiva Kumar felt that I should be given a chance. So what I'm to say is that unless we start seeing mental health care and mental health issues in the context of the larger society and social development, I don't think we can progress. So far, our models of care have been entirely hospital dependent, usually based on what we have experienced in large tertiary hospitals. And even though we have known for years, decades, that that model is insufficient, we continue to go with the same model. And therefore, our experience has been that unless good mental health care is kind of nestled within good medical and socioeconomic care, it fails to have the impact that we all wish it would have. It should be, it goes without saying, be accessible and equitable for the poor, and that is more complicated than it actually looks. Because even if we say that all our institutions are open to the poor, there are so many hurdles which make it difficult for people to access, and therefore it is not equitable. Finally, these should not be standalone, but should be community-owned and community-led. And several of these principles I will try to illustrate through our work. So I will not describe our work except in the context of these observations. This is where we are, and especially we operate in the hilly district of Wayanad, Calicut, Malappuram, and parts of Palakkad district. So we operate in 4 districts of North Kerala. Now, soon after he won the Nobel Prize for Economics in 1998, Professor Amartya Sen made a very interesting address in 1999 to the World Health Assembly, in which he made the link between development and health. And very interestingly, he said that, sorry, was there a, no, very interesting, hello?
No, you can continue, sir.
Yeah, very interestingly, he said that there is not a direct proportion between health and development. In other words, having good developmental indices need not necessarily lead to better health. And he used the example of Kerala to contrast it with the health of African Americans living in the US, and pointed out that on many health and social indicators, despite poor developmental indices, people in Kerala had better health, better life expectancy than, say, minority communities in the US, I'm sorry. So so it gives us hope in that despite our poor economic and development indices, we can actually achieve good health indices. Because even when an economy is poor, we can use different models and use the available resources in a productive way. For example, in a highly densely populated state like Kerala, healthcare, which is very labor intensive, can make use of its available manpower, which is what we have used. We use more than 500 volunteers in delivery of care, and therefore we feel we are at an advantage. The background to all this cultural developments in Kerala, which have been called the Kerala paradox or paradoxes, which is a successful experience of having high human development indices despite low economic development. And this has invited attention from economists and sociologists all over the world. And there are nuances within it, but on the whole, it is true for Kerala. So we are actually riding on the success of all these. And in Kerala, as elsewhere in India, there are both access to care issues and delivery of care issues. We have probably more psychiatrists working in Kerala than many other states, but they're all concentrated in cities. The availability of public sector social workers and psychologists are again very poor. Most of the healthcare expenses in Kerala, almost 80% is out of pocket private expenses, and there are major governmental funding issues. Services, the mental health services are still operating out of the 3 large asylums and the medical colleges and district hospitals. There is, of course, the district mental health program, which is also there. But in all these systems, there is no system or culture for aftercare. So people are given episodes of treatment and then left to fend for themselves until the next relapse. And this gets them into a downward spiral of economic difficulties, hopelessness, and indifference. As we all know, there are adherence issues amongst patients, amongst people all over the world. And here, the role of the family and society is more. So about 7 years ago, we started working in the community. And what MHAT aims to do is to provide comprehensive, good quality, community-based mental health care with a focus on rehabilitation in the voluntary, non-governmental sector in collaboration with various partners. So we have been doing it for 6+ years. We have around 2,600 patients on our books. Most are of adult working age with severe mental illnesses. And we are spread across 4 districts, 41 clinics. And it's a very, very multidisciplinary comprising of social workers, psychologists, and increasingly more of non-professional clinical workers. That is, people who do not have a background educationally, but who by training have become part of our clinical team. We have more than 500 volunteers who do various roles, but essentially they act as key workers, care workers for these patients. So each patient has a named volunteer, care worker, monitors the person and who is the point of contact for any form of help for all our patients. So not all patients have volunteers. In some remote areas, there may not be a volunteer system, but by and large, that is what we try to achieve. So moving on to how we achieve it, which is where the importance of task sharing or task shifting comes in. Patel early this year made the provocative statement that mental health is too important to be left to mental health professionals alone. And with each passing year, I could not agree but more with him. It is time that we included communities, volunteers, the vast resource of people that people with mental illnesses and their families can provide into actual provision of mental health care. So task shifting, as the WHO has been talking about for many years, is defined as delegating tasks to people who are existing or people who have who are new with very little training or with specific tailored training. So in other words, if we consider that mental health care delivery can only be achieved by us, psychiatrists, psychologists, social workers, nurses, and so on, we will not achieve the goals of mental health care for all during our lifetimes. So it is time that we thought of other models where we designate tasks, keeping safety in mind, because always the bogey of safety is raised whenever I talk of this, is it safe, especially from doctors. But unless we start taking risks with a vision on, with a view on safety, and with good supervision mechanisms, we will not get anywhere. So there are already models emerging. For example, Vikram Patel and his group at the Sangat have shown through systematic research that lay people can deliver evidence-based psychosocial interventions. For us, it is not just psychosocial interventions, but the entire program is run by volunteers and owned by volunteers. And at a deeper level, it is an attempt to break down barriers with increasingly using service users as part of the MHAT team in delivering clinical care. I couldn't agree more with my colleague from Chellamuthu Trust, who said that stigma is not such an issue in rural areas. Our experience is also that. For us, the major problem is not stigma in rural areas. And what this model of task sharing involves are cascading levels of supervision and roles. People receive supervision, play their own unique roles, and provide supervision to people who are less trained than themselves. So, for example, a social worker would receive supervision in, say, medical management, of course, with all caveats of safety, would play their own unique roles and would train volunteers in playing roles which traditionally a social worker would. So, for example, most of the outpatient services are run by volunteers and non-medical professionals. So the actual running of the clinics, the discussions which follow each clinic, and even supervision of medication is run often by non-medical professionals and non-professionals. So we have a system where the same team goes to 2 clinics every day, morning and afternoon. People are given fixed appointments, and even in rural Kerala, people do somehow manage to keep their appointments. Non-attendance rate is close to 0. New patients detailed workup, which is often by a professional, occasionally by a very good trained non-professional. New treatment is started only after a doctor sees the person. And all through this process, there is continuous contact with volunteers, and home visits are required. These are members of our team making a home visit, and then, of course, since record keeping is very important, making contemporaneous records then and there. And most of the care is centered around these 41 outpatient clinics. And a variety of things happen there. Education about treatment and medication given to volunteers. Discussion about people who are not really doing that well, and an action plan formed. Relapse prevention is the key to everything. So at each visit, patients and families are encouraged to contact their named volunteer at the slightest hint of difficulty, not just mental health related. So we encourage patients and families and volunteers to be constantly in contact with each other, so that problems can be nipped in the bud as soon as they arise. Involving volunteers in checking and encouraging adherence to medication. We have detailed plans to register all these actions which are planned. And then once people are ready, they are referred to daycare, and the evaluations for rehabilitation start. And all daycare is community-based. So the entire community-based rehabilitation happens in a decentralized fashion in these 41 clinics. And then, of course, as people get better, there is a system of continuous home visits and people being plugged into local employment opportunities. So everything is local and decentralized. And of course, if this is to work, there has to be constant support and supervision and training. So this is at various levels. At the very basic level, volunteers run clinics and look after the clinic in general. At a higher level, they may act as individual case workers or care workers, and they will receive training in mental health care skills. At a higher level, people would receive training in psychosocial interventions. In fact, we have one research program going on at the moment which will evaluate the efficacy of this. And then non-professional rehabilitation coordinators are given training in specific rehabilitation-related interventions as well. Moving on to the third thing, which is the need to focus on quality. Very often in our attempt to provide basic healthcare, we often compromise on quality. But as far as our consumers are concerned, quality is paramount. And this gives us the dilemma of how to increase the reach of what we do, while at the same time providing best quality mental health care. And that too, as far as MHAT is concerned, to the poorest people with mental illnesses, because we only focus on the extremely poor people. So the two issues we have usually in the community are people complaining that they cannot access our services because they are better off. And secondly, now increasingly, issues with task sharing, which I'll come to at the end. So the quality issues. And many things go to make good quality, comprehensive psychosocial care. The medical care has to be comprehensive, focusing on good diagnostic psychopharmacological practices and coupled with good general medical care. For that, we use local doctors, and we do not provide the general medical care ourselves, but we facilitate that. Good psychological care, both at the individual and group level. And most importantly, you cannot treat mental illnesses or any illnesses for that matter on an empty stomach. So economic care is absolutely important. And more technically, community-based rehabilitation that I have mentioned, home-based care I've mentioned several times, and also increasingly organizing people, both patients and families, into separate groups and having regular discussions with them and regular meetings is also happening. We haven't started microfinance, self-help group kind of things, but we hope to at some point. We try to instill good practices in everybody, whether they are from a professional background or not. We focus on systems in general. We have good electronic note keeping. All computers are linked to a central computer through a free software. We have good paper records in the various clinics, good illness management systems and practices, some of which I have mentioned, such as the volunteer acting as a care worker, round-the-clock telephone access. The volunteers, not the patients themselves, but the volunteers can access us at any time in the day or night. So we are continuously available to support them. And early warning systems for relapse detection I have mentioned. Is it sustainable? Is it cost effective? We are in the process of setting up proper economic analysis. So we don't have the research data to say that it is cost effective. We hope it will be sustainable because, as I said, it is volunteer-led. Most of the care and monitoring increasingly is by volunteers. It is truly decentralized. We position ourselves, MHAT positions itself as the providers of care. And we try to say that this is your clinic, your people, you are going to give them good care, we will help you in doing that. So they own it, and that sense of community ownership, community empowerment is hugely important. Increasingly, the people do not like it when I say this, but increasingly we are trying to make it deprofessionalized, not in terms of professional practices, but in terms of dependence on professionals alone in delivery of services, and therefore demedicalized as well. And as I said, the role of training and support supervision cannot be overstated. Part of the quality is also because it is completely integrated into primary care. None of the clinics will have community psychiatry or any MHAT or any such boards. So it is in the same places, which are usually palliative care centers in North Kerala, plus primary health centers in the government system, where the mental health care also is delivered. And as I said earlier, it is easily accessible. People do not have to travel more than a few kilometers to access these centers, and it is equitable. So we use existing healthcare infrastructure. In Kerala, we have access to the palliative care, unlike other states, so we use them. Primary health centers, often new groups of people who just decide to get into this and start on their own. Therefore, a small group of us can reach out to a large number of patients through a big team of volunteers. So that is the crux of the model. So in other words, it is an empowerment model of community mental health. So let me go next and we conclude this. Public mental health approach is absolutely necessary. We feel social change is also necessary for good mental health. Poverty reduction, reduction of social inequality, promoting social inclusion are all there. A broad view of mental health we feel is required, and we need to seriously discuss task sharing, including the legal aspect of prescribing. We need to think from the point of perceived quality of the mental health care. Even the poorest people would want good quality health care, and they end up paying, they end up getting into debt in order to access that, often unsuccessfully. And for all this to happen, a mindset change may be required. And before I finish the hurdles and issues, as I said, mostly there are two sets of problems. One is of access to people who are not poor. That is our problem, because we have positioned this as only for the extremely poor people. People are taken into the system after a process of screening at home. But increasingly, we are beginning to have problems with the demedicalized model, because absolutely nobody is in favor of that. Everybody would like to by a doctor. Doctors are not happy when we say that it should be demedicalized and that task can be done by others. So there is a beginning of rumblings of issues from the medical psychiatric community. For sure, because of limitation of time, I'm not elaborating on that. And I would like to conclude, as I started with Amartya and end with Amartya Sen. Ultimately, there is nothing as important as informed public discussion and the participation of people in pressing for changes that can protect our lives and liberties. And mental health cannot be seen separate to all this. Public has to see itself not merely as a patient, but also as an agent of change. Amartya Sen warned us all those years ago. The penalty of inaction and apathy can be illness and death. Thank you for giving me this opportunity. I welcome questions. Thank you.
Thank you, Dr. Manoj, for that wonderful presentation. Now the topic is open for discussion. Maybe Dr. Siva can start the...
Yes, to set the ball rolling, you said that you are trained in traditional hospital practice, and currently you are working in CBR. If you were given the responsibility of designing the training curriculum of mental health professionals, what changes would you introduce?
Yeah, I think fairly obvious. I would suggest that a significant part of the training of doctors, of psychiatrists, should be away from hospitals in settings that are in the community. Because the kind of problems that you see in a tertiary referral center, mostly chronic psychosis, severe illnesses, leads to a lot of problems when people try to practice later in the community. The overdiagnosis of schizophrenia, for example. In the community, you see a totally different pattern of morbidity. People are given very little training for psychosomatic problems, somatoform disorders, for example, and a significant part of any community mental health issues will be those. So I would suggest and hope that over time we move to a more community-based model of training. In fact, we are starting a one-year certificate in, a fellowship in community psychiatry starting next month. Sorry to put a plug for that, but I couldn't resist saying that. So we are now offering a one-year stipendiary fellowship in community psychiatry meant for fresh doctors or people who are interested.
People from the Chellamuthu Trust have a query to you, sir. Any volunteers training module, and how you and they also ask how you recognize them. How did you go on recognizing the volunteers? How did you identify them? And also they want to know about any existence of any volunteers training module.
Yeah. Yes, to the second question, yes, we do have modules which we will be happy to share. They are not in a very impressive format, but we can share whatever we have with you. And that is for training community-based rehabilitation coordinators, and as part of the research project, training volunteers in psychosocial interventions. So we have those two sets of modules which we'll be happy to share. What I have learned over the last 7 years is that if we go in search of volunteers with our model, it often doesn't work. So what we do is we wait for people to, at least even one person to contact us with an interest. We then guide them in finding like-minded people in their own localities. We don't do it. We get them to do it, to find a group of like-minded people, organize themselves, and then we start talking to them. Talk to them about our model, what it would entail for them, and so on. Similarly, we don't do a door-to-door survey to identify people who are unwell. Because very often people say that, oh, we have done a survey, we know that 40% of the people have problems, but when we start a clinic, it turns up. So we don't do that. Right? Instead, we ask these volunteers to go into their neighborhoods and localities to find out who are the people with severe mental illnesses who fit the economic criteria also. And it is for the first time that they didn't realize that they have been living in proximity to people with so many problems. Because most of the problem we choose not to see, especially amongst the poor people. But we are confident that, you know, even if we take it as a conservative 2% prevalence of severe mental illness in a populated country like in a state like Kerala, there are bound to be lots of people amongst us within a couple of kilometers, within 5-kilometer radius, who do have severe mental illnesses and who need our care. When we start a new clinic, they're always doubtful. Does this problem exist? Are there people that we can give this treatment? But within a few weeks, it is a real eye-opener for them in that they begin to come across more and more and more people. And because we keep it for the poorest of the poor, gradually they begin to find more and more poor people living in abominable conditions, even in a state like Kerala.
People from Chellamuthu Trust are also sharing with you, sir, that they also have a training module, and that's been tested, and they're willing to share that is what.
Thank you very much. Thank you. We will really look forward to looking at that.
Stop screen share. We can request it.
Sir, we could also have your screen sharing to be stopped.
Oh, sorry.
There is another query to you, sir, from Dr. Sujay Ray, who says he's a psychiatry resident and he wants some information regarding training in community psychiatry, and perhaps he wants to know from you as to whether post-MD psychiatry candidates are eligible for this fellowship course that you were talking about.
I think what we are trying to do is, in a span of a year, train people to become specialist. I'll choose words carefully. To become specialist practitioners working under supervision. So it's a kind of a condensed psychiatric training full time over a year. So a lot of the training will be basic. Psychopathology, phenomenology, psychopharmacology, and so on. So for people post BPM or post MD, at this stage in our plans, I think they may not benefit it to that extent to spend a year with us. We're willing to take people on for shorter periods of time to give them exposure, a month, 2 months, 3 months, whatever. But I generally think that post MD, it will not be of significant benefit. I think shorter periods of training we will be happy to offer.
Okay, Dr. Ravi Shankar Rao had a question. You can just.
So what do you think are the limitations of these volunteers?
The main issue is to keep them motivated and involved. Now, what we find is that the most motivating factor for them is to experience recovery in patients. So, for example, we've had people working in palliative care, then come over and start working in mental health care, and they find it significantly more fulfilling, because in palliative care there's an endpoint which often occurs sooner than later, and they have a high turnover of people, very unwell people who go on to die. So they never see people regaining lives or rebuilding lives. So that is the single biggest motivating factor for them to stay on in this role. Continuing to play a role in helping people rebuild lives. There are problems. In all our clinics, the same level of motivation is not there. So that depends on the people at the top. A lot of people get into these initiatives, so-called social work, for various other reasons. And they do not allow the rest of the volunteers to share responsibility. So the key is to make it meaningful for people and to get them to own it. That sense of ownership is what is going to sustain this.
Another query is from Dr. Arun from Christian Medical College, Vellore. He wants to know as to what happens to patients who are in need of inpatient care. How do you deal with that situation then? And what if clients refuse treatment? So these are queries from CMC.
Yeah. Again, there have been two major learning points for me in my 30 years of psychiatry. Because all along I thought, surely we need inpatient facilities, because that is where the severely unwell people got well. As the years passed by, in a given year, out of our, say, 2,000 of active patients, hardly 10 people require hospitalization. So in other words, if you can manage to keep people healthy in the community, you don't need inpatient facilities. I'm not saying that there's no need at all, because a lot of people, for their initial stabilization, might need to go into hospitals. But if you are able to provide good aftercare, then the need for hospitalization is significantly less, because I find that most hospitalization is because of dropouts and stopping of treatment and failure of aftercare. So in our experience, we find that if we can provide good mental health care in the community, there is hardly any need for inpatient facilities for that group of people. There are situations where you would need an inpatient stay, but I suspect that a lot of inpatient stays are because of the failure of on our part to provide good health care. Even though you haven't asked, I'll also say what is the second thing that surprised me, which is that you don't need to use benzodiazepines. We hardly use benzodiazepines. People still sleep well and are okay.
The second part of the question is, what if clients refuse treatment? How do you deal with these circumstances?
Yeah. Often, because in our system, there is less focus on personal autonomy, hardly ever does anyone feel that their rights have been infringed when family compels them for treatment. So often, families would take initiative to bring patients against their wish to the centers, and even to allow us to give injections against people's will. It's a gray area, ethically fraught and all that. And in a discussion setting, we always say that, of course, patients' rights are paramount, we shouldn't try to compromise on that and so on. But the real alternatives are very poor. Because if we go the legal route and get the local magistrate to commit them to the local hospital, nobody wants that. Families do not want that. They are far more happy for us to treat them against their will at times in where they stay. Nobody wants to go down the legal route. So what do? Do we treat them sometimes against their will, or do we let them continue to deteriorate in the society? So it's a tricky one. But the short answer is that yes, we do help families look after their uncooperative patients.
Yeah. So there are two more questions. One is from Dr. Aarti and next Dr. Harish.
Sure.
Happy evening,
This way.
Happy evening, sir. Your model started with community support, went on to community empowerment. I just have a query whether you do plan to or have planned in the future to translate it into a community advocacy or a rights type of model, so that it could be more self-sustainable, because you're talking about self-sustenance also. Then you could have a complete circle of self-sustenance. That's one. The second, you have spoken a lot about the macro issue, which I think is extremely important from the economics point of view. From my perspective, the reality is, after 1990s, once the structural adjustment policies came in and the markets opened up to mental health care, liberalization, privatization, and globalization of mental health care, the difference between urban-rural, the difference between accessibility, availability, and affordability of mental health care, there is a stark difference. And now, keeping this reality in mind, when we are talking about social advocacy and social policy, would you advocate for differing social policies with respect to the economics of care would be the second thing that I would like to answer.
I mean, to answer the second one first, couldn't agree with you more. It's very, very obvious that the direction that we are heading as a country, I don't want to be political, but we all know what's happening in our lurch towards capitalism and right-wing economics. The poor are losing out. There's no doubt about that. And the only way it can reverse is for communities to decide on the priorities. Local self-government has worked in Kerala to a certain extent. So the healthcare spending is devolved at the panchayat, or at least at the district panchayat level, and that is showing effect. So we should allow people, we should allow communities to prioritize and to decide on on their priorities and how to spend for that. So it has to be far more socially inclusive and community led, and that is where we are trying to pitch our tent. The first question was.
This is where I think possibly the replicability of a model like yours would require individual interventions by individual people like possibly you. Otherwise, the replicability in a reality situation of structural economics could pose a barrier.
Absolutely. Yeah. I couldn't agree more. We haven't, we started purely as a clinical provider, clinical care provider. And as years have passed, we have gotten into education. We run 2 master's level courses along with the ISS and other courses. And we are into research and so on. So there is a limit to what we can do as a purely individually funded NGO. We have no government funding. We have no corporate funding. It is entirely small donations from a large number of people. So we have to focus as well in order to survive. So that is why we haven't gotten into social advocacy, into awareness building and so on. But you're absolutely right. Those have to be integral for sustainability.
Just to repeat my second question, so don't you think that if you have systems in place, if you have social policies in place with inclusive of social advocacy, it could possibly help the movement much better?
Absolutely. That's what I said. I fully agree with you.
How do we do that?
I think we've got to see, for example, from Nimhans, you are the premier institute, and you have to encourage local initiatives along these lines. We have to spread. We have to get out of into the community more. We have to involve more and more groups, more and more people, more and more NGOs. That's the only way forward.
Dr. Harish, who had a query.
As I see a series of questions. One is, you said about 41.
One question at a time, please. I can't remember.
You said some 41 centers were there, and can you tell us where these are placed, like in district headquarters, how many, or what is the placement? You said around 5 to 6 kilometers is the access distance for a patient.
These are mostly, I don't know if you're familiar with Kerala. You don't see the really desolate countryside in Kerala. It's a series of small towns or villages. So almost all the centers are, you could say, in semi-rural areas. There are some in tribal colonies and so on, but most are, one would say, semi-rural areas or small towns. But the distances in Kerala are less. So hope that, so it's not district headquarters, no.
Who does the primary diagnosis and who prescribes the medication for subsequent visits? Because the 41 centers, I don't think these 41 psychiatrists will be sitting there. That is one question. And the patient, does he pay, or the family, they pay anything for the visit or medication procurement?
Yeah, stop. Please stop. 2 questions. There's no payment at all. As I said, we screen to ensure that only the poorest people are taken in, and there is absolutely no payment for anything. And that includes volunteers also. Volunteers are truly volunteers; they're not paid. In terms of diagnosis and prescribing, as I said earlier, unless a psychiatrist sees and confirms the diagnosis. So the workup need not be by a psychiatrist. But one of the eye-opening things have been that with training, non-professional volunteers are able to do as good a history taking and mental state examination as at least first year DPM students. So people can, when with proper training, they can do a good workup. Of course, the diagnosis is confirmed only after a psychiatrist sees. Which means that the psychiatrist is not there in every clinic. I go by rotation, and other colleagues also go by rotation. So there are days when there will be no doctor in the clinic. Again, prescribing is we start medications only after a doctor sees. Subsequent changes may be made over the phone with discussion and supervision, and that is the area we're struggling with at the moment in terms of its legality. And hopefully, we will now have a doctor in every clinic at some point, and thereby overcoming the legality of that. Next question.
Because what I understood is this is a model where you are reaching the community people nearby the doorsteps. Like, how will you say this is something different from DMHP? Though DMHP has not achieved its goal, district mental health program, the concept seems to be similar. No? Where it is mental health program only district headquarters.
Yeah. See, DMHP on paper envisages a lot of things, but what I have seen and what I have heard is that it ends up being medical camps. What I mean is that a team reaches a particular place with medications, spend say around 3 hours there, end up seeing a large number of people and often repeat medications. That is all what happens in the DMHP camps. Correct me if I'm wrong. If something more is happening anywhere, that is fantastic. But often with all the
at least not what they say in paper also. They don't say that psychiatrists should see patients in camps.
Yeah.
And I'm not sure all about PhD doctors.
And I'm afraid
is that
what you said also won't happen in most of the DMHPs, at least in our state.
Yeah. Yeah. So see, so in that sense, it is very different because there is constant monitoring by volunteers, constant feedback to us. Relapse prevention happening all the time, which is the key to our success. Rehabilitation, again, based in the same premises, run by volunteers. Psychosocial interventions provided both in the daycare setting as well as individual and group settings. So all of these things that I have mentioned may be envisaged in DMHP, but I am not sure if it happens in many places. So that is the essential; those are the essential differences.
So time permits us to have only a couple more questions. One is from Dr. Radhakrishnan, and the other one is from Dr. Prabhat. First, Dr. Radhakrishnan.
So, good evening.
Good evening.
Thanks for the good work you are continuing there. I have a question to you. What do you expect from community health nurses for the model which you have suggested? Already existing community health nursing practice is going on. And what do you expect from them, or how do they help you in terms of relapse prevention, in terms of administering the medications, and many more?
Yeah, I think in this model, the profession, there is much more common between professions than are distinct. Even when I was working in the UK, I often struggle to understand what the nursing professionals, what the occupational therapists, and what the social workers brought to the team. They all often ended up doing this more or less the same thing. And I think that goes for us also. It is just so that we haven't been able to get mental health trained nurses. But most of the same model, I feel, would run equally well with mental health nurses as well as social workers as well as psychologists. Of course, each profession would bring its own strengths. For example, individual, especially more complex psychological interventions. Of course, clinical psychologists are best placed in social level interactions. Of course, social workers are best placed, and so on. But there is a lot common to the professions. So in our situation, they are a missing group, but they can play an equally important role.
Dr. Prabhat.
Dr. Prabhat, psychiatrist at Nimhans faculty. I don't have any comments. I just want to compliment to your work. And it really shows that you have a like-minded people being together and have a reason to work, and you can do it. Resources is not always a constraint. What needs a vision, and I think and I thought it's good for me because I run the whole Nimhans Echo program. And when we started, we thought knowledge should be free and we should demonopolize the knowledge. And I was amazed because of this. I could hear to you. I have never heard you before. Thanks for coming. Thank you.
Arun from CMC has posted a question. Can I answer that?
Yes, sir. Yes. Please go ahead.
Arun, hi. Yes, we do look after homeless, mentally ill people as well. It's a different model to what Dr. Anatharyan does in CMC. We do it. Your Professor Anna does it with an NGO. I know. What we do is we do it at two levels. We provide an enriched service to the large number of so-called rehabilitation homes which are there in Kerala, where homeless people usually end up. So we provide an enriched service to such many of those institutions. But more importantly, for the locally wandering people, because each village, each town will have a number of people who do not wander away from that locality. They are familiar faces in bus stations and so on, wandering, picking at the garbage and so on. Everybody knows them. Such people, we encourage communities to befriend and to use people who are already familiar to them in the community in giving them medications and gradually rehabilitating them. When that happens, the joy is immense, and we have had some major successes in doing that. So yes, we do look after wandering mentally ill people. So in all of our clinics, we say that they should get priority because any person wandering who's mentally ill is a blot on our social functions, and we shouldn't allow that to happen. But it's a very challenging group to try to help.
Okay, if there are no questions, then let us end this program. I thank one and all, especially the presenters. So, presenters from Chellamuthu Trust, as well as Dr. Manoj Kumar, as well as all the participants for a wonderful discussion. Thank you all. Thank you very much.
Please spread the word of VKN in rehabilitation, road to recovery. We expect more people to log in next time.
We will get our students to do that as well.
Sir, the next session in this particular series will be done by Chittarama. Dr. Ravi Shankar Rao is already with us. So they will be presenting a case on rehabilitation of homeless mentally ill. So we would look forward to Chittarama to enlighten us about the unique issues which they face in the rehabilitation of persons with mental illness. We thank you all for your cooperation. The recorded version of this particular program is also being made available on YouTube in our Nimhans Rehab channel. Thank you very much.
Thank you.